What are some of the key factors that clinicians should consider when deciding whether to recommend that an HCV-infected patient should begin therapy, especially patients with challenging pre-treatment factors?
It's a very important question, but it really gets to one of my core beliefs as a clinician who's involved in this field, which is the overarching idea that all of our hepatitis C patients will be candidates for therapy. I don't think there's any such thing as a hepatitis C patient who, once these treatments are approved and available, should have therapy withheld for any but the most compelling reasons. Hopefully there won't be prohibitive cost constraints, but in terms of medical reasons not to be treated, I can only think of the reasons hepatitis C patients should be treated. Every hepatitis C patient, even if affected with only mild liver disease at a given point in time, has the potential to develop progressive fibrosis with all of its attendant possible complications. We've also learned to think increasingly of hepatitis C as a disease with systemic ramifications, including an increased risk of diabetes, certain kinds of lymphoid tumors like B-cell lymphoma, premature arterial sclerosis, neuropsychiatric problems like depression and altered cognition. And of course there's a public health problem in the sense that people are transmitting hepatitis C to each other. So to me, once we have the treatments that have appeared on the horizon, or in certain cases already have appeared, namely the oral interferon-free medications, all of our hep C patients are candidates for therapy. The major theme that has emerged in the last year or two is this marvelous leveling of the playing field for opportunity of cure across very broad populations, where there used to be sharp gradients between those who had a good chance of response, those who were blessed with genetic makeups that, for reasons that are still somewhat mysterious, predispose them to respond to interferon and do relatively well with it, and those who had a very poor chance of responding to interferon. That's all going away as these powerful antiviral drugs overcome host factors. So we're seeing treatment-experienced patients who've had very poor responses to interferon do essentially just as well as treatment-naive patients. We're seeing patients with cirrhosis, which is the most worrisome state of affairs for a hepatitis C patient, have cure rates that are very, very high as well, although there's still some question about the optimal duration of therapy with the regimen studied so far. We've seen HIV co-infected people or African Americans who have hitherto been disadvantaged in terms of the likelihood of being cured with interferon therapy achieve this state of leveling of the playing field of opportunity for cure. The only situations in which I could think of not treating patients is if, for some reason, a patient doesn't want to be treated, something that's a little difficult to imagine, or perhaps patients with very rare comorbidities that preclude the application of anything that will have yet been approved or at least adequately studied. So right now, for example, we need these fantastic regimens that we've seen so much about in the past few weeks alone at EASL, in the New England Journal of Medicine, to be studied in patients with kidney failure, because doses have to be studied carefully in such patients, particularly with drugs that are excreted by the kidneys. We need much more robust studies in people with decompensated cirrhosis. But I have a feeling that in the not too distant future we will have sufficient data, even in those still challenging populations, to know what to use with confidence in those patients to ensure the highest levels of efficacy and safety. And I can't imagine that in the relatively near future we won't be treating just about everybody with hepatitis C, as long as we can get access to the medications.